Thank you, Dr. Hunt, for a very nice topic on Achilles tendinopathy and not evading the controversies that occur nowadays in the treatment of it. So we've been talking about fracture, about ligament, about tendon, and it's an honor to have one of the biggest European biologic orthopedic researchers in our house to talk about the cartilage now, which I'm looking forward to.
Once more, thank you for joining us and sharing some thoughts about it. Even if it will not be about tissue engineering or regenerative medicine, this talk will be focused on what's going on the clinical basis, mainly on athletes. Osteochondral defects can be classified in several ways. Etiology remains multifactorial. Several things to be considered: traumatic, non-traumatic, vascularization, osteochondritis dissecans. But the clinical presentation is usually deep ankle pain increasing with activity. And this is mandatory for the choice of what to do. We all know that cartilage is very highly irrigated and innervated, right? Wrong, absolutely wrong. So where does the pain comes from? We think that most of the pain will come from the nociceptors which exist in the subchondral bone. And it's quite different to deal, and this is parts of tissue engineering, it's the biomechanical environment which influences any tissue. It's quite different when you are dealing with an incongruent joint like the knee versus a congruent joint which creates a high hydrostatic pressure always on the synovial fluid against the subchondral bone. And if you have a crack, a leak on this cartilage protection, this will make some fluid get in, and the osteolysis process might start, and you get irritations from the nociceptors which are highly present in the subchondral bone. So most of what we are doing on the clinical setting is treating the subchondral plate and not the cartilage itself. And if we want to know how to repair cartilage, I will leave that talk to Professor Mats Spritzberg that sits here with us for tomorrow. So how do we deal with it in 16? Once more, keep it stupidly simple, listen to your patient and see where do you have from evidence-based medicine, meaning which support do you get from literature from this, and what's your clinical practice? And this is the way that we are going to deal mainly and particularly if we are speaking about high-level athletes, highly demanding and very short window for failure. So we see that this is a systematic review that has been published in 2010 from the Amsterdam School. And based on the findings, and here in defense of what Peter was saying and my strong will that the tissue engineer will come up, what has been analyzed is the first generation of chondrocytes implantation. I hope this will improve in future. But for now, the best available results come from bone marrow stimulation techniques, in some selected cases, oats, drilling, which might be part of the bone marrow stimulation techniques, and fixation of the fragment whenever possible. This is something which I find quite new. This is a philosophy that started with Nick van Dijk and now highly developed by Gino Kerkhoffs, the lift, drill, fill, fix option. Meaning, whenever possible, in trying to preserve as much as we can the biology of such a big injury, we should, even in this important injury, chronic, with big cysts, maybe it is possible to lift it, drill it, meaning prepare and do some bone marrow stimulation, go from the distal tibia, which is right next to the injury site, pick up some bone graft, fill it, and then put some screws to fix it. And this, we hope, it will preserve better the future. This is the final picture, and you see that this is our first option, because so far, for as much as I want to be reliable in reaching hyaline cartilage repair by tissue engineering, we are not there yet, unless Professor Britzberg tomorrow can bring us some novelty that will make us all change. So most of our practice, mainly in high-level football players, is kept about bone marrow stimulation techniques. But once more, this is not a single-shot procedure. A la carte is becoming a famous sentence in this conference, but this is also the case. We must consider the location, the width, the depth, because all this should be taken into account. One more thing, don't rely on your MRIs alone. Why? Because MRIs, particularly on the T2, they tend to overestimate the injury that you get, because all this edema impairs you to seeing how far is the disease of the bone. And we need to check before we go to the operation room how much bone, how much floor to stand up do we have. So in part of my pre-op planning, there's always a role for the CT. And this is the CT on this injury. And now, what about the approach? How can I approach this injury? Shall I approach it from anterior or posterior? And this is another information. Our CT is always made in full plantar flexion and full dorsiflexion for pre-op planning. You see, this is the dorsiflexion CT, and we confirm that if needed, I can approach it from posterior, like we saw from Peter. And now this is the plantar flexion CT. Well, this will be a little bit tricky, but I'm used to do it. I can also approach it from anterior. And my personal choice, whenever possible, I go from anterior because I am closer and my range of freedom with my motions of my instruments, it's higher. I can work better than if I have higher distance with a soft tissue envelope on posterior approach. So this is what is done, and microfractures that we can now argue if they can be done micro, nanofractures, or nanofractures, or microfracture enhanced with PRP, hydrogels, cells, whatever. The third option, we will leave this part for discussion if you are willing. The third option is Mosaicplasty. This has been proven to be effective, and Laszlo Angodi has even published a very nice series on soccer players with Mosaicplasties for ankle, but as far as I know, is the only one reaching this quality of results. One thing that I bring to your attention, and this is a real life case, is that by grafting inside the knee for treating a football player which has a complaint on the ankle, it's something dangerous because you start with one problem and you get to risk of ending up with two serious problems. This was the case because even more, he developed focal osteoporosis, so he got neuroalgodystrophy on the donor place. And you see this is the analysis of the harvesting. And one other thing, shall I do this kind of repairs arthroscopic or open? I say do what you are used and effective to do. The most important is treat the injury. It's not being at this point in time, stubborn just because I read something about it or because I heard a guy about it, and I will do it arthroscopic or open because of this or because of that. Because open repair or open approach of this kind of injuries is not always better because you will not always see much better. This is a case, this is a real case that came to me in these phases. It is the same as the one before, in which you see, I believe you have definition enough to see, the nicely put cylinder. It's very well compressed, very flat with the surface. It would be quite okay. Okay, but the defect was posterior to it. So this patient received, this is the original defect, posterior to the injury. This patient received a very nice cylinder, but with, you see the screws from the medial malleolus osteotomy, but he received a very nice cylinder completely out of the place of the injury. So open surgery doesn't always mean that you see better. Okay, take this into account. He had this mass inside his knee, and look at this criteria. It will not be easy for biology of the patient to fully recover from this. Here you see the aspect of the cylinder, but the defect, which was relevant, was much more posterior, and it could be approached from anterior arthroscopy, because this is the view that you are seeing now. Of course, it's my scope, it's my field of research. We are trying to build some cell-based therapy, even advanced tissue engineering therapy, meaning that we can combine nanotechnologies with scaffolds, cells, and make these scaffolds intelligent in the way that we can use nanoparticles to make the cells turn on sometimes, turn off another time, and make them rich in some sort of growth factors or not in a way or another. And this should be at least bilayered, if not three-layered, to be effective. What we also tried, and we have just published, it's not in press anymore, it's published, is if the patient comes with a problem in the ankle, let's harvest cells from the ankle. We have the idea to go for the posterior process or ostrigon, and on this zone, you can either get mesenchymal stem cells from the fat or autologous chondrocytes for further implantation, depending on the way that we are moving now, and these are the results that have just been published. One other thing, ankle is also a weight-bearing joint, so alignment is critical. This is not a footballer, but this is, it used to be a professional boxer fighter. And he came with an ankle like this, and he said, "Doctor, I still want to do my last fight. So I want to prepare myself to do my last fight. I don't want a fusion." And we have learned from several biomechanical studies that if we shift the load transfer on the talus for 1 millimeter, it will decrease the load bearing for 40%. And if this shift is around 2 millimeters, it will increase close to 60%. So this osteotomy is quite a powerful tool in selected cases. And this was the outcome that we achieved, and he did his last fight. He did the last fight 6 months ago at the age of 42. So he has an ankle that he moves, but I don't advise this, of course, on a football player. Distal tibia osteochondral defects. For several reasons that are not very well understood, these do less well than the ones in the talus. We get a little bit more concern in the small ones, but even more in the big ones. Check once more. If I selected the worst picture, it seemed that the old medial malleolus was gone, which is not true. You get your CT to see how big is the disease bone. This is an athlete, active athlete, and check. If you search closely, you will be able to find a crack on the cartilage, which makes the fluid get inside and further degeneration of this. From the scope, you open this crack to destroy the valve mechanism, because if there is a valve mechanism, the fluid gets in, but it cannot go out. So you open it just a little bit, but you see, this cartilage looks quite right, quite okay. Do I have a better cartilage for this patient today? I don't think I have. Maybe Professor Bitzberg will make us do it in future, but for the moment, no. So I will try to preserve it. And I will go for surgery on a retrograde approach. This sort of devices gets you to be on place in an easier way. And then with a trephine, you take out the diseased bone, you use the good part of this bone for later grafting, enhance it with some more grafting. One thing you can do in these big injuries, you can do osteoscopy, meaning you can put the arthroscope inside the tunnel that you have created and control when you are working around the clock, around the area, to remove all this diseased tissue and create nice bleeding bone, laterally filled with bone graft. Close the window, because this is the window we used for reaching the injury. And only because I was scared, I put, and this was a really big injury, I put these 2 screws for biomechanical support. And I don't know if they are needed or not, but it's a decision I took. And this is a 2 months follow-up, and he is already back to sports. So, keeping on, for failure cases and for revision, we have some new sets of options, but once more, they are not for active footballers, but maybe they can allow people to be more active in sports, like this EMICAP procedure that the Amsterdam School came up with. And the last option would be fusion, because the concern about ankle replacement is something for a different talk in another day that we can have. Coming back to our starting point, based on literature, currently trying to keep it stupidly simple and make our athlete come back to return to sport, creating the less aggression possible, our first options would be the bone marrow stimulation technique, in large cystic lesions, retrograde approach for the same matter, fixation in big lesions, but I would say whenever possible, and all the remaining, I would leave them for revision. So I strongly believe in this algorithm today, 2016, that is the summary of what we have just said, and it was a courtesy from Nick van Dijk. And remember, in our hands, doctors sometimes can always make bad things even worse. So take caution from your decisions. And I thank you so much. Particularly, this is true, of making bad things worse, particularly when you are dealing with high-level football players, being futsal or beach soccer or open soccer. And the good thing is that we have a lot of people highly motivated to work on this and to make this better. So we have some expectations for future, and we will have some more discussion about it very soon on isokinetic meeting, then Barcelona, and then ISOCOS in Shanghai. So hope to see you soon. Thank you.